Hello, everybody. I'm Jiang from Peking University People's Hospital, Beijing, China. First, I will thank the invitation from CML Foundation. My topic is how we can amend these recommendations to reflect local needs in the emerging regions. At which stage of the disease is that CML usually diagnosed? From 2006 to 2019, more than 1,000 patients with CML were diagnosed in our hospital. The median age was 40 years old. At diagnosis, 85% of the patients were diagnosed in the chronic phase, nearly 15% in the accelerated phase, less than 10% in blast phase. 1/3 of the patients diagnosed of CML because of routine examination, 1/3 examination for other disorders, and 1/3 because of CML-related symptoms. We analyzed the cause for CML diagnosed by social demographic variance. We found the lower educational level was the only variable associated with CML diagnosis because of CML-related symptoms. In the CP patients, 62% of patients were in the ELTS low risk, 26% intermediate risk, less than 10% high risk. We found male lower educational level and diagnosed because of CML-related symptoms was significantly correlated with an ELTS score of intermediate or high risk. Which scheme of TKI therapy are available? Nowadays, in China, we have the TKIs as follows. We have no third-generation TKIs available in China. Only ponatinib and HQP 3051 are in clinical trials. This is a survey last year we performed across China. Nearly 3,000 of questionnaires were analyzed from the CML patients. The median age of the respondents were 38 years old. Imatinib was the mainstream TKI in China. Regarding the first line choice, the first TKI choice, the patients from rural area with lower educational level and from central regions of China and in the chronic phase will prefer to choose generic TKIs as the first choice. And the younger patients, those unmarried in unmarried status and those in advanced phase will prefer choice the second generation TKI as the first line TKI therapy. During the median TKI treatment of 6 years, 73% of patients achieved at least MMR. 40% of patients had a TKI switch. This is the initial TKI therapy pattern. This is the current pattern. The patients with TKI switch. This is a TKI switch pattern. The first line TKI was imatinib. The second line, dasatinib and nilotinib. The third line, and the first line, the third generation TKI was the mainstream of the first line. This is the data from our hospital, similar to the data from the survey of China. Imatinib is the mainstream TKI of the initial TKI choice or at the last follow-up. How do you make decisions on switching therapy, and what determines your choice? We usually, according to the milestone, based on the ELN recommendations and tolerance of the TKI therapy, age of the patients, comorbidity, cost of the TKI, and the patient's treatment goal. We analyzed the data from our hospital. We found male, single status, lower education level, the ELTS in intermediate or high risk, and imatinib as an initial therapy were associated with the lower rate of cytogenetic and molecular responses. Next, we found the male, elder age, and single status, lower educational level, and the ELTS intermediate or high risk, the patient's response to TKI therapy. This is the result of the survey performed 5 years ago. 1/3 or more than 1/3 of patients performed the molecular monitoring every 3 months in the patients receiving branded TKIs, including Gleevec, Tasigna, and Espresso. At that time, the patients receiving Chinese generic imatinib or foreign generic TKIs have a lower frequency of the molecular monitoring. There is a significant difference between the patients receiving branded TKIs and the generic TKIs. Are you trying to implement a TKI discontinuation program? Also, this is also a survey result from the a survey result 5 years ago. Nearly half of the patients reported TFR was their treatment goal. In the future, 83% expect to discontinue TKI therapy. But in the patients, in the 17% of the patients who did not expect to discontinue the TKIs, the main reason was fear of disease relapse or recurrence, or the TKI resistance. When I ask the patients if they can stop the TKI when they meet the criteria of stopping TKIs, they found no. I will watch and wait, because they said the successful rate of the TFR is relatively lower. So we have a project of TKI dose reduction before stopping. Just for the patients eligible for TFR, prefer to remain on therapy and adopt a watch and wait and watch strategy because of the relatively lower TFR success rate and the fear of disease recurrence. The patients are willing to try dose reduction therapy to alleviate the adverse effects of the TKI therapy. I think maybe during the dose reduction therapy, those who are ultimately suitable for discontinuation can also be screened out. What do you feel the biggest challenge is in your country to implementing the international guidelines and the recommendations to the full extent? The first is the clinical care by some unprofessional physicians or in specific and specialized referral center. So some patients are under the care of unprofessional disease management. The second is the lack of careful consideration for discontinuation or switch. For the patient, we usually find that patients experience the toxicity, the hematologic toxicity at the early phase, early stage of the TKI therapy, such as at 1 or 2 months. But at 3 months, the BCR-ABL more than 10%. Some patients, some physicians suggest the patients to switch to another TKI. I think maybe this is a hematologic toxicity, but not an intolerance. Maybe we can try to continue the same TKI therapy at a relatively lower dose, but because inappropriate or unnecessary interruption, reduction, or switch, which may cause more severe toxicity and cost, poor response or outcome. So this is the second challenge. The third is imprudent pursuit of TFR. Some physicians recommended the patients to choose or switch a patent drug for pursuing TFR without considering the potential toxicity caused by the second generation TKIs. And some patients perform the molecular monitoring in the unreliable referral centers. And the patients have irregular monitoring before or after stopping TKIs. A resistance received illegal and reliable copy drugs, which might lead to undesirable poor outcomes. In those patients, maybe early transplant will be recommended. How we can amend these recommendations to reflect local needs? We hope to clarify the initial choice for ELTS intermediate or high-risk patients in the new version of ELN recommendation. Maybe the second generation TKI as the first line choice. Hope to emphasize the identification of TKI toxicity or intolerance. For example, the hematological toxicity within 3 months, and careful recommendation for continuation a low dose therapy or switch to another TKI at an appropriate dose. Hope to clarify the definition of failure. Only based on the milestones and the referring chronic phase in the current version of ELN recommendation, is intolerance or progression to advanced phase included in the definition of failure? Hope to clarify the significance and the right time of NGS in detecting BCR-ABL and non-BCR-ABL mutations. How to define the pH-negative MDS or AML during TKI therapy? Even though there is very real patients, can we define this transformation or progression? Regarding low-dose TKI therapy, recommended for those with at least MMR, expecting to reduce long-term toxicity, when and how to reduce the dose, what is the lowest dose of each TKI based on the dose optimization studies. This is a situation in China. How about in other countries? We will ask the hematologic leaders from Mexico, Ethiopia, and Nepal. Thank you for your attention. Thank you for my team.